दर्शन मात्रे मन कामना पूर्ति। जय देव जय देव।
लंबोदर पीतांबर फणिवर बंधना सरळ सोंड वक्रतुंड त्रिनयना दास रामाचा वाटपा हे सदना संकटी पावावे निर्वाणी रक्षावे सुरवर वंदना।
जय देव जय देव जय मंगल मूर्ति दर्शन मात्रे मन कामना।
व्हाट अ ब्यूटीफुल सेरेमनी। मैं माननीय मुख्यमंत्री जी का हार्दिक अभिनंदन करती हूँ और बहुत बहुत धन्यवाद देती हूँ कि उन्होंने हमारे लिए इतना समय निकाला। अब मैं डॉक्टर नरेश त्रेहान सर से आग्रह करूँगी कि वो हमारी ऑडियंस को संबोधित करें।
गुड मॉर्निंग, नमस्कार, प्रणाम सर। आपका बहुत बहुत स्वागत है और मुझे पता है कि आपको जाना था और आपने अपना प्रोग्राम चेंज करके यहाँ ब्लेसिंग देने के लिए कि सब हम डॉक्टर इकट्ठे हुए हैं, तो उनका पूरा जोश बढ़ाने के लिए आप आए, इसका बहुत बहुत थैंक यू। तो मुख्यमंत्री जी, पहली बार जब मैं अमेरिका में था 20 साल और एक हार्वर्ड यूनिवर्सिटी में मैं लेक्चर दे रहा था, तो एक अमेरिकन जो प्रोफेसर था वहाँ पे, उसने मेंशन किया कि भाई आप तो हिंदुस्तान जा रहे हो, हार्ट करोगे, ये करोगे, पर बीमारू स्टेट्स का क्या होगा? तो मैंने पहली बार ज़िंदगी में बीमारू स्टेट का नाम सुना था। तो मैंने उससे पूछा कि वो कौन सी है भैया बीमारी, तो उसने बताया कि बिहार, ये वो सब। तो उसी दिन मैंने उनको बोला कि सबसे पहली जो सर्विसेज होंगी जो मैं करने की कोशिश करूँगा, वो सारी जो आप बीमारी स्टेट करें वो आपके मुकाबले की होंगी आने वाले टाइम में। तो आज ये खुशी है कि आपके कर कमलों से जो आपने उद्घाटन किया मेदांता का, उससे आज बहुत अच्छे डॉक्टर मिले। वो फैसिलिटी तो थी, आपने देखी, पर सबसे बड़ी बात यह है कि जो खामियां थी, जो प्रोसीजर पहली बार भी होने थे, जो हमारे जो डॉक्टर लोग हैं बिहार के, वो सबसे विद्वान हैं मेरी ओपिनियन में, क्योंकि दुनिया में कहीं चले जाओ तो लीडिंग डॉक्टर्स बिहार से। तो इसीलिए ये हमारा उत्साह बड़ा था कि बिहार के डॉक्टर इतने अकम्पलिश्ड हैं कि उनको अगर जो हम एक जगह बना दें और टेक्नोलॉजी दे दें तो वो कमाल बिहार के लिए भी होगा, और वो हुआ है। ये आप लोगों की बहुत बहुत धन्यवाद है आपका। तो इसको और चलाना है और बिहार में क्या करना है वो आदेश आप देंगे। जैसे आपने इसका आदेश दिया था वो बन गया। अब मैं चाहता हूं कि आप लोगों की डायरेक्शन मिले। सेक्रेटरी साहब से बात भी हो रही थी कि कैसे ये स्पिरिट जो पीपीपी स्पिरिट करी है इसको कैसे आगे चलाया जाए। तो एक तो मैं सब डॉक्टर्स को बहुत थैंक यू करना चाहता हूं, अब दूर दूर से आए हैं, और हमारा प्रयास रहेगा कि ये सब हम इकट्ठे जुड़ जाएं तो जो बिहार की जनता है वो जो भी लास्ट मैन स्टैंडिंग भी है उस तक भी जो बेस्ट पहुंचा सकते हैं पहुंचाएं। तो सर्विसेज तो आप समझ लेंगे आज के दिन में, और कल के दिन में आपको सारी सर्विसेज के बारे में बताया जाएगा। डॉक्टर गुलेरिया भी आए हैं, दिल्ली से भी आए, ये भी संपर्क करेंगे आप लोगों के साथ। हमारे और भी फैकल्टी मेंबर्स हैं, डॉक्टर प्रमोद ने तो बताया ही, और हमारे साथ सारे जो साथी हैं सीनियर लोग, और मिस्टर पंकज सानी जो हमारे ग्रुप सीईओ भी हैं, इन सब के साथ से ये तय है कि जो आप लोग हमारी गाइडिंग फोर्स हैं, आप डॉक्टर्स, और जो आप समझेंगे कि करना चाहिए और कम्युनिकेट करें, तो कोशिश करेंगे कि वैसा ही होगा, क्योंकि बिहार तो 13-14 करोड़ लोग हैं जिनकी सेवा करनी है। तो मैं मुख्यमंत्री जी का टाइम बहुत लिमिटेड है, तो मैं ज़्यादा स्पीच वीच नहीं देना चाहता सर, सिर्फ थैंक यू करना चाहता हूँ आपको, क्योंकि इनको अपने घर जाना था, कोई उसका तोड़ के प्रोग्राम यहाँ आए रुके कि इसकी ब्लेसिंग करेंगे। तो सर मैं आपको पहले ही रिक्वेस्ट करता हूँ इनका प्रोग्राम का उल्लंघन करके आपको रिक्वेस्ट करता हूँ कि आपको हम ज़्यादा देर नहीं रोकना चाहते, आप जितनी देर सबको संबोधित करें वो आपकी मर्जी। ठीक है।
आज ये मेदांता कॉन्क्लेव के आयोजन में मुझको भी आपने बुलाया, इसके लिए बहुत बहुत धन्यवाद। और यहाँ पर उपस्थित डॉक्टर नरेश त्रेहान जी, और बड़ी खुशी की बात है कि यहाँ पर डॉक्टर रणदीप गुलेरिया जी भी यहाँ पधारे हुए हैं। अब इनका रिश्ता तो थोड़ा नरेश त्रेहान जी से भी हो गया है, लेकिन इनसे रिश्ता मेरा बड़ा पुराना है, ये आप जान लीजिए। ये तो एम्स के ही थे हेड, तो उससे बहुत पहले से हमारा इनका रिश्ता है। तो बड़ी खुशी हुई हमको कि ये भी यहाँ पर मौजूद है और आपका भी कुछ सहयोग कर रहे हैं। और बहुत अच्छा, बहुत अच्छा आ गए। अब पंकज सहनी जी मेदांता के CEO, और यहाँ पर उपस्थित हैं डॉक्टर प्रमोद कुमार जी, डायरेक्टर एवं HOD कार्डियोलॉजी, डॉक्टर अजय सिन्हा जी, डायरेक्टर कार्डियोलॉजी, डॉक्टर राजीव रंजन प्रसाद जी, डायरेक्टर रेडिएशन ऑन्कोलॉजी, डॉक्टर संजय जी, डायरेक्टर CTBS, डॉक्टर रविशंकर प्रसाद जी, मेडिकल डायरेक्टर, श्री दीपक कुमार जी, पूर्व मुख्य सचिव और मुख्यमंत्री के प्रधान सचिव आपके सामने बैठे हुए हमारे साथ आए हैं, श्री संजय कुमार सिंह जी, सचिव स्वास्थ्य विभाग, और इस कॉन्क्लेव में भाग ले रहे सभी प्रतिष्ठित चिकित्सकगण, और यहाँ पर प्रिंट और इलेक्ट्रॉनिक मीडिया के पत्रकार मित्र भी यहाँ पर मौजूद हैं, छायाकार बंधुओं, और इस कार्यक्रम में उपस्थित बहनों एवं भाइयों। आप लोगों ने एक नया कार्यक्रम जो किया है, सर्वप्रथम इस वेदांता कॉन्क्लेव 223 का जो आयोजन किया है, और उसमें सभी बहुत डायरेक्टर साहब को आप लोगों ने बुलाया है। और सिर्फ यही नहीं, अभी तो आप बिहार के डायरेक्टर की बड़ी प्रशंसा कर रहे थे, इसके लिए बहुत बहुत बधाई आपको। लेकिन बाकी तो आप सब जगह से लोगों को बुलाए हैं, मैं सबका अभिनंदन करता हूँ। यहाँ पर आए हैं और विशेष तौर पर आप चर्चा करने वाले, तो ये बहुत बड़ी बात है कि आप आपस में चर्चा करेंगे कि किस तरह से क्या होना चाहिए। और आपको मालूम है कि हम लोग जो यहाँ पर मेदांता हॉस्पिटल बना, तो इसका नाम हम लोगों ने दिया है जयप्रभा मेदांता सुपर स्पेशलिटी हॉस्पिटल। अब आप सोच लीजिए कि एक जयप्रभा के नाम से था, अब उसके लिए वहाँ पर बहुत काम नहीं होता था, तो हम चाहते थे कि बहुत अच्छा हो। तो इनसे भी हमने बातचीत की कि आप कीजिए, तो तैयार हो गए। और इसके लिए यहाँ पर इन्होंने मेदांता के काम को शुरू करने का निर्णय लिया, और जिसका शिलान्यास किया गया 2016 में, और 2020 में ही ये सब काम करके इसको करना शुरू कर दिए, और कितना बढ़िया ट्रीटमेंट हो रहा है। तो ये बड़ी खुशी की बात है। और हम तो कितने लोग आपके यहाँ ट्रीटमेंट में अब आते हैं, और कितने अच्छे डॉक्टर्स हैं, और सबको बड़ी खुशी होती है। और शुरू में तो हम जब शुरू किए थे, जानते हैं ये मेदांता का, तो उस दिन जिस दिन 2016 में कर रहे थे, तो कुछ लोग कुछ बोल रहा था, ऐसे ही बोल रहा था कि अरे साहब ये तो जयप्रभा का था, आप किसी को क्या करवा रहे हैं। तो हमने उसको कहा था कि अरे जयप्रभा का कोई काम हो पा रहा है, हम तो चाहते हैं कि यहाँ हॉस्पिटल बने। तो खैर एक दिन ऐसे ही कुछ लोग बोल रहा था, उसका तो उसके बाद तो किसी को ध्यान भी नहीं है, याद भी नहीं है। हमको तो यादें रहेगा सब दिन कि हम जो काम कर रहे थे तो उसी समय कुछ अंड बंड कोई बोला था, और जब बन गया ये तो कितना ज़्यादा लोगों को खुशी, आपके हॉस्पिटल से कितना लोग प्रसन्न हैं। और आपसे तो मेरा दोस्ती अब बहुत पुराना न है भाई, जब हम एमपी रहे हैं और दिल्ली में रहे हैं या वहाँ केंद्र में मंत्री रहे हैं, तब से ही आपका संबंध हमारा है ना। इनसे तो मेरा संबंध हुआ है जब हम यहाँ थे मुख्यमंत्री, तब 7 से मेरा इनका संबंध है। मेरी पत्नी की तबीयत खराब हो गई थी, बहुत हालत खराब थी, तो बची नहीं, तब उनको देखने आए थे वहाँ से, तो उसी समय से मेरा रिश्ता है। और इनसे तो मेरा और पहले से रिश्ता है। तो जब यहाँ पर हम लोगों ने कहा कि एक हॉस्पिटल बनाइए, अब बनाने का इन्होंने निर्णय लिया, बहुत अच्छा। जमीन तो हम लोगों ने दे ही दिया, लेकिन 300 का कर दिए, और अब तो और भी उसको ज़्यादा बढ़ाना। हम लोग तो बराबर मिलते हुए रहते हैं, और उसमें 25% को सुरक्षित रखा गया, यानी गरीब तबके के लोग, ऐसे लोग जिनकी आमदनी परिवार की 250 से कम है, 2.5 लाख से कम है, तो उसको एक कम हम लोग राज्य सरकार की तरफ से दिए हुए हैं। और दूसरे जितने सरकारी कर्मचारी हैं तो उनके ट्रीटमेंट के लिए भी यहाँ पर हम लोगों ने 1/4 25% सुरक्षित रखा है। तो उस पर भी काम अब तेजी से शुरू होना चाहिए। हमने तो डिपार्टमेंट को कह दिया कि वो भी काम कराइए, और उसके लिए जो भी लोग, ऐसे लोग हैं गरीब तबके के लोगों का इलाज और सरकारी कर्मचारियों का, सरकारी अधिकारियों का जो इलाज होगा, तो उसके लिए तो राज्य सरकार पैसा देगी। हम लोग देते हैं मुख्यमंत्री चिकित्सा सहायता कोष, तो उससे हम लोग मदद करेंगे, और बाहर भी करते हैं मदद, तो बहुत अच्छा है। अब एक चीज हमको आग्रह करना है आपसे यहाँ पर, वो ये है कि देखिए कि आपका जो है इतना बड़ा सुपर स्पेशलिटी हॉस्पिटल है जयप्रभा मेदांता हॉस्पिटल, अब यहाँ और चिकित्सा सुविधाओं का विकास किया जाना चाहिए। एक हम आग्रह करेंगे कि कैंसर के इलाज के लिए बिहार से लोगों को महाराष्ट्र में भेजना पड़ता है, टाटा मेमोरियल हॉस्पिटल, और उसके लिए हम लोग यहाँ से भेजते हैं। सब के लिए जो सहयोग देना है वो सहयोग हम करते हैं। तो हम आपसे आग्रह करेंगे कि जरा सा यहाँ पर, आप तो इतना बड़ा बड़ा सब कर दिए पटना से लेकर के दूसरे सभी जगहों पर, तो यहाँ पर तो आप जब शुरू किए थे तो सबसे पहले आपको तो आग्रह हम यहाँ का किए, यहाँ पर शुरू हो गया। तो मेरा आपसे निवेदन है और अनुरोध है कि एक आप यहाँ पर कैंसर के इलाज का भी आप जरा सा यहाँ पर पटना मेदांता हॉस्पिटल में काम शुरू करा दीजिए, बहुत सुविधा होगी। सबको जो भेजना पड़ता है हम लोगों को महाराष्ट्र में, तो भेज जाते ही रहेंगे, जो जैसे जाएंगे वो जाएंगे, बहुत अच्छा ट्रीटमेंट है। लेकिन आप जब चाहिएगा भाई, आप बैठे हुए हैं गुलेरिया साहब भी यहाँ, तो जब गुलेरिया साहब भी बैठे ही हुए हैं, तो दोनों के सामने हम कह रहे हैं कि यहाँ पर जरा शुरू करा दीजिए, मेदांता में आप लोग कैंसर का भी इलाज करवा दीजिए, तो बहुत अच्छा रहेगा। और आप लोग नए ढंग से जो बात कर रहे हैं, तो वो तो नए ढंग से बात करिए और करके और कैसे ट्रीटमेंट किसी का हो। लेकिन एक बात हम आपको अनुरोध करेंगे कि आजकल तो हो गया है कि नई टेक्नोलॉजी आ गई है, सब कुछ बाहरे सबका ट्रीटमेंट हो जाएगा। तो भाई एक बात हम बता देते हैं, देखिए अभी 100 साल से ज़्यादा देश नहीं रुकने वाला दुनिया, क्योंकि जितना ज़्यादा ये अब मोबाइल का इस्तेमाल हो रहा है, पुराना चीज तो सब अब भूलते चला जा रहा, और जो चल रहा है सब उसी को देखता है, तो बड़ा अच्छा ना हो गया है। लेकिन आप तो जानते ही न है कि जब शुरू हो जाता है, जब जब पृथ्वी खत्म होता है, तब तब यही होता है कि अंत में इस तरह की टेक्नोलॉजी आ जाती है, और उसके बाद अचानक किसी दिन वो भंग हो जाएगा और सब आदमी मरने लगेगा, मर जाएगा, खत्म हो जाएगा दर्द। तो उसके बाद तो हालत आप जानते हैं, इसलिए हम हाथ जोड़ के प्रार्थना सबको करते हैं। हम जानते हैं 19 में देखे उनका स्टेटमेंट जो था, जो जिनका डेथ हो गया था, जिन्होंने ये बात कही थी, तो उनको दो देख करके हमने कहा था, ये जो कहा था उन्होंने, स्टीफन हॉकिंग, तो बड़े नामी आदमी थे, तो उनका तो डेथ हो गया, तो उनका हम कागज पढ़े थे। तो पहले कह रहे थे 200 साल, उसके बाद वो कहा कि 100 साल में खत्म होगा। तो हम तो अब ज्यादा जो मोबाइलवा देखने वाला काम मेरा पहले था ना सबको, अब हम कम कर दिए, नहीं देखते, हमको छोड़ दिए। अब बाकी सब, अब मेरे जितने स्टाफ है पहले मेरा एक एक बतवा याद रखते थे, अब आजकल सब यहाँ बैठे हुए, देखिए ना कितना सीनियर है सब, अब वही देखते रहते हैं। तो हम इनको कहते हैं कि अच्छा देखिए तो 17/7 में ये काम हुआ, तो इन लोगों को बड़ा देखना पड़ता है ध्यान से, बड़ी। तो सब पुरानी चीजों को तो भूलते ही जाइएगा। तो इसलिए हम आग्रह करेंगे कि जो करना है जहां, लेकिन भाई डॉक्टर साहब को सबको रखिए, डॉक्टर साहब जरूर देखें। खाली ऐसे ही कोई दूसरा तरह से उसको मशीने से इलाज हो जाए वो नहीं, हम तो आग्रह करेंगे। आज तो आप लोग सब बात करने वाले हैं, तब बात तो करिए, वो तो आप लोगों को अधिकार है। लेकिन मेरा विनम्र निवेदन है कि जितने डॉक्टर्स हैं वो डॉक्टर्स भी पूरे तौर पर लोगों को देखने में और लोगों का ट्रीटमेंट करने में सक्रिय रहिएगा, ये मेरा निवेदन। और हम लोग तो जान रहे हैं ना भाई, बिहार में कितना ज्यादा हम बढ़ाए हैं, हॉस्पिटल बढ़ाए हैं, कितना ज्यादा हम मेडिकल कॉलेज हॉस्पिटल बनाए। पहले जब हमको काम करने का मौका मिला था तो उसमें मात्र 6 था, अब बढ़ते बढ़ते हम लोगों ने कर दिया है 11 और 14 का काम चल रहा, और ज्यादा हम तो अब कह दिए कि हर जिला में करेंगे। जैसे इंजीनियरिंग कॉलेज हर जिला में बना दिए हैं, हम भी चाह रहे हैं कि हर मेडिकल कॉलेज हॉस्पिटल हर जिला में बना देंगे। तो इस तरह से ताकि किसी को दिक्कत नहीं हो, सबका ट्रीटमेंट हो। तो हम लोग तो पूरा लगे हुए हैं, बिहार में जितना ज्यादा कर सकते हैं। डॉक्टर्स लोगों ने कितना मेहनत किया है। अब पहले तो बहुत कम लोग, बड़ा परेशान रहता था, अब सबका ट्रीटमेंट हो रहा है, लोग देख रहे हैं। और हम तो सबको कहते हैं कि यहां पर भी करेगा, लेकिन किसी को यहां से बाहर जाना है तो बाहर जाएगा, नहीं तो पहले क्या हालत था। तो हम लोग तो खाली इन्हीं के हॉस्पिटल से ना मतलब था, हम लोग जब MP बन करके गए तभी से ना हमको रिश्ता है वहां से, अभी भी हमारा रिश्ता वहां। लेकिन जो बाकी अब यहाँ सब जो काम करवाए हैं, यहाँ भी एम्स बन गया है, सब तरह की चीजें यहाँ सुविधा हुई है, वो सब तो कर ही रहे हैं बाकी सब लोगों का। और आप जानते हैं जो सबसे पुराना हमारा है पटना का मेडिकल कॉलेज हॉस्पिटल, अब आपको मालूम है कि उसका हम लोग क्या करवा रहे हैं पटना में। उसमें हम लोग कर रहे हैं कि अब उसमें ट्रीटमेंट होगा 5040 का रहेगा एक दिन में पूरा ट्रीटमेंट, और उसके लिए 3 फेज में बनवा रहे हैं। ये दुनिया का सबसे आगे रहेगा। PMCH का करवाने जा रहे हैं हम लोग, सब काम करवा रहे हैं। तो ये सब काम तो करवे करेंगे। लेकिन अब आ गया सब तरह से हम लोगों के यहाँ सब तरह के हॉस्पिटल को बढ़ाना, और तो सारा सुविधा हो रहा है। तो हम तो यही कहेंगे कि हम लोग भी यहाँ पर तो सब लोगों के इलाज का प्रबंध, किसी तरह को दिक्कत नहीं हो, और सब लोगों को अगर कोई असुविधा है तो उनको हम लोग मदद करवाते हैं, ये सब काम करवाते हैं। लेकिन अब आप जो हम आपसे अनुरोध किए हैं वो जरा कैंसर वाला जरा आप शुरू करा दीजिएगा, उम्मीद करें ना हम, करें उम्मीद ना। तो बहुत 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 धन्यवाद आपको।
आपको आश्चर्य होगा कि जो आपने आज हुक्म दिया है वो 2 महीने में कंप्लीट हो जाएगा।
बहुत अच्छा, इससे खुशी की बात नहीं। मैं इसके लिए आपको बहुत बहुत धन्यवाद देता हूं और आपका अभिनंदन है। जिस दिन शुरू हो जाएगा आपका नमन करने हम आएंगे, आप समझ लीजिए। तो इन्हीं शब्दों के साथ आप सब लोग आए, बहुत अच्छा है, और सब काम करते रहिए। और चूंकि हमको जाना है भाई, हम तो शुरू न करवा दिए हैं, सब पार्टी की एक साथ राय के आधार पर जाति आधारित गणना, जनगणना तो केंद्र करेगा। तो शुरू हो गया है, एक राउंड हुआ, दूसरा राउंड अब हो रहा। तो हम तो अपना घरवा जहां जन्म हुआ है, तो आज शुरू हुआ है, तो हम वहीं ना जाएंगे भाई, अपना ही सब चीज देखेगा। घर ही पर जा रहे हैं, इसीलिए आज ही कह रहा था, हमको कल ही खबर किया कि वहीं शुरू कर रहे हैं। तो हम कहे ठीक है, वहां पहुंच जाएंगे। तब पहले तो हम थे कि आप जितना देर कहिएगा बैठे रहेंगे, लेकिन जब आ गया तो हमको वो लोग भी कह दिया है कि 12:30 तक आइए। तो हम कह भाई 12:30 तो नहीं, लेकिन 1 बजे तक हम जरूर पहुंच जाएंगे वहां, तो इसीलिए हम आपसे आग्रह किए कि हमको दीजिएगा, और आप इतना अच्छा काम कर रहे हैं, और आप सब लोग जो आपस में चर्चा करिएगा, मुझको बड़ी खुशी है कि इसका बहुत फायदा होगा, ताकि लोगों का इलाज बहुत बढ़िया ढंग से हो और सब चीज़ों का इलाज हो जाए तो खूब अच्छे ढंग से हो। तो इसके लिए आप लोग और चर्चा करेंगे। इसके लिए मैं आपको बहुत बहुत आपका अभिनंदन करता हूं, आपको बहुत बहुत धन्यवाद देता हूं और अपनी बात में समाप्त करता हूं।
आदरणीय मुख्यमंत्री जी श्री नीतीश कुमार, डॉक्टर त्रेहन, डॉक्टर गुलेरिया, डॉक्टर कुमार और डॉक्टर सिन्हा, सर जिस तरीके की आपने बातें की थी कि मेदांता में बिहार पटना में मेदांता जयप्रभा हॉस्पिटल खुला, और मुझे याद है जब आप उद्घाटन पे आए थे तो उस समय कोविड की महामारी की बीमारी खूब चल रही थी। अब गुलेरिया साहब शायद हमें बता देंगे कि आगे वो महामारी खत्म हो चुकी है कि आगे और भी चलने वाली है, लेकिन एक साल में जो मेदांता ने आगे सारे स्पेशलिटीज़ में जो काम किया है उसके लिए मैं सारे डॉक्टर से बहुत आभारी हूँ। जैसे आप कह रहे थे कि जो कार्डियक, गैस्ट्रो, न्यूरो स्पेशलिटीज़ तो चल ही रही हैं, लेकिन मेदांता जयप्रभा में आज की तारीख में हमारी जो मेडिकल ऑन्कोलॉजी कैंसर की सर्विसेज हैं वो शुरू हैं। दो बहुत महान कैंसर के डॉक्टर्स, जिसमें से एक टाटा मेमोरियल से ही पढ़ के आए हैं, वो मेदांता जयप्रभा में काम कर रहे हैं, मरीजों का इलाज हो रहा है। जो हमारे सर्जिकल ऑन्कोलॉजी हैं, चाहे वो न्यूरो कैंसर हो, चाहे वो गैस्ट्रो कैंसर हो, चाहे वो फीमेल कैंसर हो, ब्रेस्ट कैंसर हो, गाइनोकोलॉजी कैंसर हो, उनके सर्जरी भी चल रहे हैं, चाहे वो हेड एंड नेक कैंसर हो, वो सारे सर्जरीज ऑन है। और कल ही डॉक्टर त्रेहन के साथ सारे डॉक्टर्स की चर्चा हो रही थी कि ये आगे जनता को कैसे बताया जाए कि ये सारे सर्विसेज उपलब्ध हैं। और मैं ये भी बहुत खुशी होती हुई बता रहा हूँ आपको कि जो मेदांता जयप्रभा में जो रेडिएशन ऑन्कोलॉजी की सर्विसेज शुरू होने वाली हैं, उसकी जो मशीन की जो बेस है वो परसों ही हॉस्पिटल में आई है, वो इंस्टॉल हो रही है। और ये मशीन जो सबसे उच्च टेक्नोलॉजी की, जिसे हम बोलते हैं एज मशीन, पूरे हिंदुस्तान में सिर्फ तीसरी मशीन है और पूरे बिहार में पहली मशीन होगी, जो मेदांता जयप्रभा में मेरे ख्याल से 2 या 3 महीने में वो शुरू हो जाएगी। तो कैंसर की जो पूरी सर्विसेज है वो कंप्लीट हो जाएंगे उस मशीन को ऑन होते ही। दूसरी बात, मैं ज़्यादा समय नहीं लूँगा आपका, लेकिन दूसरी बात मैं ये बताना चाहूँगा कि हम जैसे लोग जो एडमिनिस्ट्रेशन देखते हैं, हमारा काम हॉस्पिटल बनाना, मशीनें खरीदना, लोगों को रिक्रूट करना, मैं समझता हूँ ये काम अभी भी काफ़ी आसान काम है। जो असली काम है वो मेदांता के अंदर जो बसे हुए डॉक्टर्स हैं वो कर रहे हैं, जो ना कि टेक्नोलॉजी और साइंस के माध्यम से काम कर रहे हैं, बट जो बिल्कुल दिल से काम कर रहे हैं, जो मरीजों की सेवा कर रहे हैं। तो उसके लिए भी मैं चाहूँगा कि आपका भी आशीर्वाद उनको दें, क्योंकि जो असलियत होती है कोई भी अस्पताल की, वो मशीनें और बिल्डिंग से नहीं बनती, वो डॉक्टरों से और जो अंदर की डॉक्टर की जो आत्मा है उससे बनती है। तो हाँ जी, बिल्कुल सर।
हमारे डॉक्टर प्रसून घोष भी आए हुए हैं सर। ये किडनी ट्रांसप्लांट के माहिर हैं, हिंदुस्तान में सबसे ज़्यादा किडनी ट्रांसप्लांट्स के मतलब जो 4-5 गिने चुने लोग हैं उनमें से हैं। तो मैं आग्रह कर रहा था सेक्रेटरी साहब से भी कि हमने अब किडनी ट्रांसप्लांट शुरू करा है, मतलब उसके लाइसेंस के लिए अप्लाई किया है। तो जितनी जल्दी उसका लाइसेंस मिल जाए तो वो सुविधा यहाँ भी उपलब्ध हो जाएगी। लिवर ट्रांसप्लांट का भी सब, हाँ, क्योंकि ये जो खामियां हैं, पर ये आपने जो बोला कैंसर का, ये कैंसर का कंप्लीट ऐसा नहीं मिलेगा आपको कहीं, सिर्फ टाटा मेमोरियल में भी शायद मिले, या वो यहाँ पे स्थापित हो रहा है और 2 महीने में वो मशीन लग जाएगी, फिर आप उसका देखना कि जो आपने आदेश दिया वो पूरा हो जाएगा। तो सब डॉक्टरों का आभारी, और आप अपना 1 बजे वाला कार्यक्रम जब भी चाहें। ठीक है, थैंक यू, बहुत बहुत धन्यवाद आपका।
We'll resume the session now. So our cardiology session was interrupted in between. So one talk is left of Dr. Pavan Kumar Singh. For that, I would like to invite our chairpersons, Dr. BP Singh. So I think Dr. BP Singh is not here. Dr. Vipin from Reuben Hospital. So I'll request Dr. Vikas Singh sir to be a chairperson. Dr. Ajay Kumar Sinha sir. Dr. Ravi Vishnu sir, please join us as chairperson for the next session. So the topic for the next session is management of acute MI, what's wrong in Bihar. It is an academic as well as a social session. So I'll request our chairperson to please introduce our speaker, Dr. Pavan. Also request Dr. Vijayshil Gautam sir as a chairperson. Dr. Vijayshil Gautam sir, please come as a chairperson, join us.
Very good afternoon, everyone, and let me introduce the next speaker, Dr. Pavan. He is consultant cardiology at Jayaprabha Medanta Super Speciality Hospital. After completing his MBBS and MD from BJ Medical College, Pune, he has done his DM cardiology from SAIT GS Mumbai, and he has expertise in primary and complex angioplasties, adult and pediatric, non-invasive and intervention cardiology procedures. So, without wasting time, Dr. Pavan, if we can hear from you.
Thank you, sir. A very good afternoon, and respected chairperson, panelists, and dignitaries. Without wasting any time, further delay, and I would straight away go to the topic. That is management of acute MI. What's wrong with Bihar? Why we are discussing, why there is the need to discuss this topic? Actually, slides. Why we are discussing this topic? Over the last few decades, India has witnessed a huge increase in the incidence and mortality of the ST elevation myocardial infarction. Number of the younger population with acute MI is increasing. The recommended reperfusion therapy with fibrinolysis and the percutaneous coronary intervention is available only to minority of the patients. This huge gap in care, it needs to be addressed. And the aim of the discussion is not to put a blame on anyone, rather to increase the point of care for the acute myocardial infarction patient, so that good standard of care can be given to patients in our state also. What does the guidelines say? If any patient with chest pain comes to the emergency, then urgently ECG has to be done, and the diagnosis of STEMI has to be done on the basis of this ECG. Once the diagnosis of a STEMI is made, then the clinicians or the first medical contact, he has to decide whether the primary angioplasty can be done within the time duration of less than 120 minutes. If it is, then PCI, he has to refer this patient to the PCI capable center. If not, then the decision of the fibrinolysis or the thrombolysis has to be made, and if it is available to that center, then it has to be done then and there, or if it is not there, then patient has to be transferred to the fibrinolysis or the thrombolysis capable center. Then what is happening in our state? This slide or the next few slides will be the observation. We will discussing the observation based issues, and I am pretty sure that most of the clinicians will agree with having the similar opinion. Whenever the patient had the chest pains, out of ignorance, denial and disbelief, considered it as gas. Try home remedies like many things like lemon water, jeera water, pudina hara, finds no relief. Then goes to the quack or the nearby pharmacist, and the pharmacist or the quack tried experiments every medications like IV pan, dichlor, dilona, antibiotic. Even if there is no relief, then patient rushes to the physician. This is the social bias we are facing due to the unawareness about the cardiac symptoms. Then goes to the physician where ECG shows myocardial infarction, and by the time patient reaches to our encounters with the first medical contact, the valuable time is lost. We know in cardiology that the time is muscle, and we are not losing the time, we are losing the muscle, cardiac muscle. And only handful centers are thrombolizing the patient. This may be due to the out of the fear, if anything goes wrong with the patient, then they will be in problem or trouble. So this is the fear bias. And hurriedly patient is referred to the PCI capable center. Even sometimes we find that so there is a patient is deprived of antiplatelet and the anticoagulation. Only in handful cases patient is referred to the center where thrombolysis is done. This is due to the clinician's bias, where they don't feel the urge or need to send the patient where the thrombolysis can be done within the duration of the 2 hours, and the viable myocardium can be saved. Since government centers capable of doing PCI located only in the Patna, many patients get admitted in the nearby hospitals and they get symptomatic treatment. Due to the poor health infrastructure, there is delay of the precious hours before patient reaches PCI capable center. This is the infrastructure bias. After patient reaches the PCI capable center, his treatment relies heavily on the time. This is the diurnal variation. If the patient is lucky enough to reach the hospital in the day or by evening, then the PCI is done. Otherwise, another few hours of the precious hours is lost till the night passes. In many cases, we find very hard time to convince patient and their relatives about the urgency and the need of the doing revascularization at the earliest. This is due to the mental unpreparedness of the patient and the relatives, and the denial of the patient and the relatives to get the revascularization at the earliest. When doctors and patients both are ready, then comes the financial issue. This is the CSI NRC data of 2019, which shows that out of total primary intervention, the 13% was the 13% was the primary angioplasty, and the share of Bihar was less than 1%. Out of the total 57,512 primary angioplasty, the share of the Bihar state, our state, was less than 1%. And this slide shows the similar picture. This is the data of primary PTCA from our center, and we have done in the last 6 months around 70 primary angioplasty, and only 6 patients could arrive within the window period of 3 hours, less than 3 hours. Total angioplasty we have done during the last 6 months, it is 441. Out of those, the number of primary angioplasty we have done 70, and only 4 patients out of that 70 could not be saved. Average time to transfer MI patient from emergency to cath lab in our center is less than 5 minutes. And door to wire time is less than 12 minutes, around 12 to 13 minutes. It is so because there is one dedicated cardiologist at any point of time in our center available, and whenever the patient reaches emergency, we alert the cath lab, it is activated, cardiologist see the patient in the emergency, counsel the patient, and that is the dedicated transport team which transfer the patient from emergency to cath lab within least possible time. Then what is the way, what is the solution? So the success story of this Tamil Nadu STEMI program and the hub and spoke model has given us hope that in the resource limited condition, if we use our resources judiciously, effectively, and integrate our peripheral health care delivery system, that is the spoke hospital, to main PCI capable center in the that is the hub hospital, then we can decrease the mortality, morbidity of the acute myocardial infarction patients, MI patients, and we can definitely increase the reperfusion percentage. Various state government, they are running the schemes which provided the financial assistance to the needy patients without any delay. And after this successful implementation of this TN STEMI program, it is now being implemented in various states like Goa, Andhra, and the Maharashtra. Few words about the spoke and the hub model. Here, this is the, I'm not getting this slide. Hub A and Hub B, where Hub A is that center which is doing capable of doing PCI at any point of time, whether it is day, night, 24 hours, they have the facility of the doing PCI, while Hub B, it is the center which performs PCI only in the working hours. If a patient comes after the working hours, then thrombolysis is done. It is attached to the spoke C hospitals, which can transfer the patients within 30 minutes of the durations. They don't have the fibrinolysis capability, and the spoke D, they are far away, more than 30 minutes, but they have the fibrinolysis capability. They will thrombolyze the patient and then transfer the patient to the PCI capable center, that is Hub A and Hub B. So whenever patient reaches this spoke hospital with the chest pain, ECG is done, and this ECG is relayed to the cardiologist sitting at the Hub A and Hub B. He makes the diagnosis of STEMI and confirms that case and makes a decision whether thrombolysis is to be done or not. Once the decision is made, then at the spoke D, thrombolysis is done and patient is transferred at the earliest for the early pharmacoinvasive strategy. This is the map showing cath labs in Bihar. It is easily visible that now the number of the PCI capable centers has increased tremendously over the last few years, and if we integrate our peripheral healthcare delivery system, we can definitely implement this model and increase the point of care for the STEMI patients. Can we change the scenario? Sure. Social bias can be minimized by increasing awareness, educating people by about the cardiac symptoms. Anganwadi worker can play the pivotal role. Fear bias by proper counseling the attendant, and by replicating this spoke and the hub model. With shared responsibilities and combined efforts, we can and we will definitely change it so that the best possible care of AMI patient can be taken, which will benefit our society, state, and the country. Thank you.
Thank you, Pavan. Thank you, Pavan. Thank you very much. Yes. We have stalwarts sitting here. I will request one of first Dr. BP Singh, because he is the key person, pivotal person in organizing things at IGIMS. So what is your viewpoint? What is your idea? What is your concept of treating acute MI in Bihar?
Dr. Pawan has very well explained the actual situation, and it is very difficult. Whatever angioplasties are being done as a primary angioplasty, I don't think they are primary. Majority of them are not primary.
Yes.
The cardiologists are turning the position the patient had the chest pain 1 hour back, and that way the primary angioplasty is being done. Majority of the time, I'm not blaming anybody. The first of the things, what my experience at IGMS was that, since 2015, we could do only 50 or Ravi used to hear exact data, angioplasty. And not all those cases were the primary angioplasty, really in the sense.
I agree. I totally agree with you.
So the one thing is to popularize among the general physician, amongst the masses, that primary angioplasty is the treatment of choice.
So
If this is not clear to the
do you feel that sensitization of society is the most
society
important?
and the general physician
Sensitization
too.
of society is the word.
And the second,
The doctors will not do.
no,
Not do the solution.
society.
Yeah. Thank you very much.
Second point is that still we should go for the facilitated one.
Yes.
We should develop the center for the thrombolysis. I don't think the majority of the patients, only 20 or 30% patients are getting the thrombolytic agents, even today.
Thank you, sir.
That
Thank
is very
you.
sad story,
Can
sir.
you-
Only
very
20
sad
patients,
story.
very
Can I
sad.
switch over to Dr. Vijay Gautam, who stays in London?
Yeah.
And he'll tell us some scenario about things happening in UK. Vijay.
Thank you so much. First of all, I want to congratulate you very much for this excellent presentation. I want to congratulate my good friend for being the pioneering drive, the energy, the effort. How much work he does, I have a good idea of how much work he puts into this. I'm grateful to my colleague over there who's said exactly right that what we are suffering from is not 100 categories of bias, but one bias, cultural bias. Everybody sitting here is at risk of having MI. We need to demand that when we have our MI, we should be getting PCI as quickly as possible. And you'll see how quickly the transformation will take place. I have to thank Dr. Pramod, who inspired me when I was here to think about getting PCI facilities attached to the emergency department, to the reception room. So when I went back to London, I said, I need a PCI attached to the emergency reception. And we got that. So there is a development, there's an evolution that is taking place. There is a skills gap, there is a training deficit, and my good friends are working on it. And I think what we really need is a big commitment to training more and more people to do the PCI at the right place. There's only two things I would like to bring to the table, with your permission. The first is the idea of diverting the local centers to go to the super center. Because the more we stop at each place, the more time we are wasting. So we need to have a direction for whoever is bringing the patient to know where to take the patient. Because right now, patient is being diverted to different places and is losing time. The second thing to remember is that everybody should be able to tell what a STEMI looks like. STMI is something that should be possible to tell looking at the ECG. This is what it is, this is what we are dealing with, and we need to take this patient to Dr. Ajay and Dr. Pramod.
So I request Dr. Pramod, because he has been instrumental in bringing PCI, primary PCI, to the stage of Bihar. So Dr. Pramod, can you give your expert comment? Because you are presented also, you have tried with the government also to stimulate them to come out with the idea of primary PCI.
You know, like everyone has agreed that primary PCI is the way to treat. And the second thing which Dr. BP Singh said was facilitated PCI. So Mr. Sanjay is here, Secretary to the Health Department. Pankaj is here. They know how much they work to get patients to the place where a PCI can be done quickly. We need very, very good support from the government. Without the government support, it cannot be done. It's impossible in this state. All over the country, especially in Tamil Nadu, Maharashtra, every patient who has MI is treated free of cost in a government hospital or in a private hospital. The total cost is borne by the government through different schemes. So something like that, first thing is like what Pawan showed, spoke and hub model has to be developed in this state also. The primary health centers, the subdivisional health centers have to become places where an MI can be diagnosed and thrombolysis can be given immediately. Then most of these cath labs should be integrated into one, so that we know that whichever is the nearest cath lab, this patient can go there. Whether it's a private or it's a Sarkari, it doesn't matter. The patient priority is to reach a place where an angioplasty can be done. If it cannot be done during night time, then the patient has to move to a place where it can be done during night time. So this is exactly the model which Tamil Nadu follows, Karnataka follows, Andhra follows. I'm at a pain to say that for some reason, state of Bihar has not listened to us. You know, Mr. Sanjay is here. We have tried our level best to reach the higher authorities to tell them that our patients are suffering. They end up spending lakhs and lakhs of rupees and go back home dead. So this is a request, earnest request from us.
Thank you.
So that something can be done. It should be organized.
Great vision, and thank you very much. Dr. Guleria, Professor Guleria is here. He has a huge experience while he was in All India Institute. And you know, I will ask you to quick comment on this issue. How can you improve the scenario in Bihar?
So I would actually agree with what has already been said, that there has to be a lot of coordination between the government sector and the private sector in developing a network, I would say, of being able to provide primary PCI at the closest site and being able to facilitate it by being able to support it financially and having the infrastructure available.
Thank you, sir. Can I have a quick comment from Ravi Vishnu, who has been editor of our journal, Bihar Journal of Cardiology. Sir.
There should be the teaching among the physician. First, not the primary angioplasty is the first. First we should thrombolize the patient and then send the patient to the nearby center.
Yes. So pharmacoinvasive is the answer.
Pharmacoinvasive
is the answer. Good. So Vikas, can I request you to summarize the whole issue now?
Sir, I strongly feel any problem solving as a prerequisite requires a good understanding of the problem. What is the problem? What are the problem areas? And Dr. Pavan has done a wonderful work in sorting out the problems. What actually stops from getting a primary angioplasty done in Bihar? Right from the level of the patient's perspective to the biases at different levels. And we have to work at all the levels together. If the patient lands up in a center which is equipped to do a primary angioplasty, there is hardly any delay if the patients or the patient's attendants are willing to get it done. But prior to that, before landing, if 36, 48, 72 hours are gone, we all know there is hardly any benefit we are going to give to the patients in a vast majority of the cases.
Do you think that activating the ambulance services to have a quick ECG, transmitting the ECG to
everything
a cardiologist?
Anything which minimizes the time gap, right from understanding patients,
and what about
recognizing the
pre-hospital thrombolysis?
That definitely will have a role, sir. In a state like Bihar, where a lot of time is wasted in transportation to the hospital, pre-hospital thrombolysis will definitely bring down the time.
Several times I have discussed with Sir, Dr. BP Singh, about this concept, that you thrombolize on the way when coming to hospital. When you start from home, thrombolize the patient. After confirmation, you send a snapshot of the ECG to a qualified cardiologist and have a concerted effort. It is not just one cardiologist will rule the whole state or Patna or something like that. You have a chain of group of cardiologists. Any person can be informed. You have a ECG, confirmation of ST elevation MI, and do accordingly. If the distance is far away, solution is thrombolysis. Thrombolize and then let the patient come. So do you agree on this point that we can, because Mr. Sanjay Singh is here, he would appreciate the idea of thrombolizing in the ambulance and activating the ambulance system before the patient comes to hospital. So, Sanjay, would you like to comment on this? That is it possible? Sir? Is it possible that patient can be brought to the hospital on the way, drug is given to clot lysis, clot dissolving drug is given on the way, and you have an ambulance system? You can govern all the ambulance system in the state. What is the problem? And if you can do this, yeah.
Comment on the whole scenario.
Yeah. Thank you. Thank you. Sanjay, please.
Thank you. So sorry, I could not. I was not keeping track of the entire conversation. What I can make out is, see, the state of Bihar now, for last about one year, has improvised its referral transport considerably, and the ambulances. Their geographical scattering is very good. We have today requested Dr. Trehan and the Medanta hospital to pitch in and train our emergency medical technicians to give the emergency services better during the transit. I don't see any reason why it can't be done. The patient transport and the care during the transport, the facility is there with better training, and the new advances that have come in, it can be done. Thank you very much.
Thank you, sir. Thank you very much. Yes, sir. Please.
Dr. When I was there, I tried to make it. What government has to take a decision, that the one vessel angioplasty will be done free. One vessel angioplasty will be done to the needy free, either at Medanta or IGIMS or IGIC.
Wherever.
The
Yes.
government has to take a decision, and the thrombolytic drug will be made available free.
Absolutely.
2 or 3
Absolutely.
points has to be made, given
This is a
proposal by
wonderful
the
point.
IGMS and the other Medanta to take as a whole the issue. The situation is not that government should take a decision that acute coronary syndrome, acute ST elevation my needs care of the government. Unless until we will be speaking, this treatment is not going to be done.
ठीक डॉक्टर बीपी सिंह, आप तो इतना दिन रहे हुए हैं आईजीएमएस में एचओडी. देखिए क्या है कि स्टेट एक अपने तरीके से चलता है, राइट, और अभी तक का जो पैराडाइम था वो था यहाँ सब कुछ की एसेंशियल क्या है. तो देर इज समथिंग कॉल्ड एसेंशियल ड्रग लिस्ट इन गवर्नमेंट विच वी आर बाउंड टू प्रोवाइड, और उसकी कोशिश हमारी जारी रहती है. रिसेंटली the government of Bihar has expanded its EDL from 293 to 611, and we have included most of the cancer related drugs. I am not a doctor. I don't know whether such precision medicines related to cardiology have been included in the list or not. I have to see it, but we can certainly call our cardiologists, our doctors are here, sit down. I think many of them are included, some of them, as you said, if not included, it can be included, and we'll certainly do. We are committed to giving the, reducing the out-of-pocket expenditure of the people of Bihar.
Sir, the cost of thrombolytic agent right now would be around 400-500. What do you think? Rupees.
कुछ नहीं, हम तो 35,000 का ड्रग देते हैं हीमोफीलिया.
Why not thrombolytic agent?
हीमोफीलिया और इन सब में 35,000 का देते हैं. 400 का क्या है?
These programs are running well in other states. That has to be adopted here. That is that has
Yes.
to be adopted.
Yes, sir.
Dr. Sinha and Dr. Pramod and also Dr. Pavan, I don't know where he is, but I just wanted to say one or two things that came to my mind. First is that I had the privilege to visit the Cleveland Clinic maybe around 2018 or 2019. And in their cath lab, of course, they have complete posters of the first coronary angiography that was done. But they had inside the cath lab, they had a poster which showed the team which was the fastest in door to needle time. And they were showing there 26 minutes. So you and your team, sir, are doing in 16 minutes. You are performing better than Cleveland Clinic. So my congratulations to you. Second thing that I was listening to the hub and spoke model which you had presented, and also the discussion around whether we should do antithrombolytics in the ambulance or not. Now I am not a doctor, so I will caution that nobody should take any advice which I say seriously. But in my hand right now, I am holding a 6-lead hospital grade ECG device. This is from a company called Alive Core.
Yeah.
We partner with them in the their United States company. We partner with them in Gurgaon, and I think we should partner with them in Patna as well.
Yeah.
The issue, in my opinion, is not about this company. I don't know whether this will be able to diagnose acute MI or not. But my belief is that the technology exists. The technology today is not the issue. The issue actually is either the mindset of our clinical community, and in that I include everybody, including hospital administrators, nurses, everybody, that we should embrace this technology, and the awareness of the public that this is available. So I often ask my friends who are non-doctors, I said that you have heard this word cholesterol. How did you hear about this word? And my personal belief is the reason they heard about this word is because Pfizer invented a drug called a statin, and they put it on the cover of Time magazine, and they had to sell this drug. So they had to promote this word to everybody so that they can come and ask their cardiologist, do I require statins? I think my cholesterol is high. Otherwise, why should people know this word cholesterol? It's a medical term. So my only request to all the folks in the entire clinical community is that if we want to be in a position to embrace and improve acute coronary care, whether it is getting the door to needle time or the door to balloon time down under 30 minutes, or whether it is getting the patient to the right center, or the right center where you have the right kind of treatment, so that you are being able to provide that care in, as even the Chief Minister was saying, in a comprehensive manner, whether it's cardiac or cancer. Awareness is a huge issue. And I have been sitting here taking notes. Yesterday I said that probably I'll understand only 1 or 2%. I think these small things around making awareness beyond only the doctor fraternity into the common public around what is the importance of this time is a very important thing. So that will be my request to everybody, not just the Medanta faculty, but everyone.
Thank you very much.
Thank you, sir.
Alive Core is a very cheap device, sir. Sanjay Singh, sir. I have it because whenever I go to US, I buy one. And this is only $100. Only $100. It's nothing. And it will diagnose MI because it is now 6-lead ECG. So 6-lead ECG will diagnose MI. You are keeping 2 thumbs on your knee. Touch it like this and it will make a diagnosis. So it's very simple. And you can, and you can convey this message to any phone you like across the world. Across the world. So it's very easy. Nothing great about it. So, any comment, Dr. Gautam, last minute comment?
Last 30-second comment. जितनी बातें काम की कही गई हैं इतनी देर में उतनी ज़्यादा कहने, इससे ज़्यादा कुछ कहने को है नहीं. एक तो टेक्नोलॉजी इज पार्ट ऑफ द सोल्यूशन, और दूसरी चीज़ है कि हम लोगों ने बहुत काम किया है भारत सरकार के साथ कि पैरामेडिक्स को ऐसे ट्रेन किया जाए कि मरीज को सही हालत में सही जगह पे ले जा सकें. दैट इज समथिंग मेदांता कैन लीड इन दैट. एक जो स्किल्स डेफिसिट है हमारे यहाँ, उस स्किल डेफिसिट को ओवरकम करने के लिए.
Yeah, so diagnosing the MI at the correct place, at the correct time, and shipping the patient to the correct place, this is the answer. Thank you very much. Thank you all.
Thank you.
So that was a very thought-provoking session. We have finished our cardiology session and we'll move on to our cardiothoracic and vascular surgery session now. So I'd like to invite our chairperson for the same, Dr. Arvind Kumar sir, senior most cardiothoracic surgeon, ex-director, IGIC. So please, you are welcome on the dais. Dr. Sanjeev Kumar sir, director, CTVS surgery, AIMS, Patna. Dr. Dheeraj Shandilya, CTVS surgery, senior consultant, Alexia Hospital, Begusarai. Dr. Sheel Avnish, CTVS head of department, IGIMS. And Dr. Manmohan, CTVS surgeon, Director, MediHeart Hospital. I'd like to invite Dr. Vipin Kumar, senior consultant, cardiology from Ruben Hospital, Patna. Dr. Vipin, please, you are welcome on the dais. Now we'll start off the session. Our next speaker is Dr. Sanjay Kumar, Director, Cardiothoracic Surgery, Jayaprabha Medanta Hospital. He is an excellent surgeon and has already done more than 550 open heart surgeries. So I'd like our chairperson to introduce Dr. Sanjay.
Thank you, madam. It's a great pleasure to be here, and more pleasure to introduce my young colleague, Dr. Sanjay Kumar, a brilliant surgeon He's presently the director of CTVS at Jayaprabha, Medanta. He did his MS from Patna, PMTS, Patna Medical College. Following that, he did his MCS from SMS Medical College, Jaipur. And he had the opportunity to work under Dr. Trihan and Dr. Anil Bhan at Gurugram, Medanta. Following that, he continued with the Medanta group and he was in Ranchi. And he managed the show very well there, so much so that he was selected to lead the team at Patna. His special interest in aortic surgery and heart failure surgery. Now I will request Dr. Sanjay Kumar to give his talk on the cardiac surgery perspective in Bihar. Dr. Sanjay Kumar.
Thank you, sir. Thank you very much for introduction. And my dear respected seniors, colleagues and juniors. Cardiac surgery can't be possible without team and will require a lot of teamwork, and with me, Dr. Praveer is here. He is consultant cardiac surgery, and we both of us are ready 24/7 for the well-being of the patient. And along with me, Dr. Rajiv is here, who is heading the critical care department, cardiac critical care, and we are ready all the time for a patient's benefit. So, when I was in Delhi, lot of patients used to come from this area. So Dr. Trehan envisioned the concept of Medanta at doorsteps, and Bihar and UP was the centers which were identified. So first took over the Ranchi center from Apollo, and there I restarted the program, and once this place has come up, then he forced me, he told me to start the program. So what we are doing today at Medanta is not less than in Delhi or any other metros, but definitely there is a lot of scope of adding the other programs and going on further. So as a cardiac surgery journey starts from the open heart surgery, which is started in 1950, to the now hybrid and robotic surgery, and in the CABGs like coronary bypass grafting, so from all the venous graft to the total arterial grafts, and from low risk patients to the high risk patients. And in the valve replacement, which gradually we are switching over to the repairs, and definitely going for the latest generation of the valves, and from minimal invasive to the least invasive surgeries, and search for a total artificial heart, and safety from rather 200% mortality. We started with the cross circulation in 50s to the less than 1% mortality in cardiac surgery. So in the statistics of the cardiac surgery at Jayaprabha Medanta, total number we have done so far in 1.25 years, 550 cases. Isolated CABGs, definitely at every center, coronary bypass grafting remains the main surgery, approximately 385, and complex CABGs, and we redo cardiac surgeries and aortic root replacement for among these 5 aortic dissections. And even in COVID era, one COVID positive patient got aortic dissection, and we operated in the middle of the night after finishing all the theaters and sealing all the theater for the rest of the staff. And you can see in cases of the surgical revascularization, isolated CABGs, 99% were done off pump, and which is the latest, which by this we can avoid the side effects, you can say, from the heart-lung machine, or in the age group of 20 to 85 years, and include the high-risk cases, because this is a common problem among the population, that if patient is 70 plus, they used to say at this age, how can you do a cardiac surgery? But this is a age when we got these patients. So it can be done safely in even at the age of 85 years. And these cases include the high-risk CABGs and with the 99% of the safety. In the complex CABGs, which include the open heart surgery, include the valvular intervention, like the most of the acute MI or posterior inferior infarcts, along with the moderate to severe mitral regurgitations. In those cases, we have to intervene in the mitral valve in form of the mitral valve repair or replacement. And coexisting rheumatic heart disease, in which we have to replace the mitral, aortic, or even tricuspid repairs. And along with this, we also get the cases of ventricular septal rupture, in which we have to intervene after stabilizing the patient, and these patients usually require mechanical circulatory support, mostly in form of IBP, but if provided, ECMO will be beneficial. And with the optimum use of technology, we can fix all these problems safely. What are the latest trends in the surgical revascularization? We had to accept the change, and mid-cap and MICS is going to be the future by this, by minimal incision of 4 or 5 centimeter in the anterolateral thoracotomy. We can do all cases of CABG, including the triple vessel diseases. And Lima is gold standard, and BIMA is ultimate in the selected patients. And radial artery has been revived as a conduit, but saphenous vein is always life-saving. In the emergency conditions, once it's come to the severe, veins are always savior for a surgeon as well as a patient. And what we practice at Medanta is a concept of heart team, in which clinical cardiologist, interventional cardiologist, critical care specialist, and cardiac surgeon, we used to discuss along with the attendant about the safety, how much safety every procedure can provide. And then with the consent of the attendant, we proceed for the treatment selected by the attendant itself. If some comorbid patient referred for the CABG, and then I go with Dr. Pramod, Dr. Ajay, and Dr. Rajiv, and used to assess the risk of doing the coronary artery bypass surgery and risk of going for the angioplasty if it is possible. Then definitely it is beneficial for the patients as well as the society and for our profession. And in this conclusion, CAD has been established, even now government has accepted that the non-communicable diseases are the leading cause of death in our country, and among these cardiac causes of death remains the maximum impacting number in the deaths in the non-communicable disease. So government is also working on preventive measures, and major trials like Syntax trial, Freedom trials have confirmed that CABG remains the gold standard in terms of survival and the intervention-free life in the future. And we had to incorporate the newer technologies like multiple arterial conduits, off pump or on pump, that is surgeon's choice, but definitely minimal invasive cardiac surgery and robotics going to be the future. And the valvular heart diseases, mitral valve repair, mitral replacement, and all kind of combinations of the valves, including the emergency stuck valves and redo surgeries. In the valvular heart disease, we are using all kind of valve prostheses which are available in the market, depending on the choice of the patient, which is driven by the finances and as well as the patient's choice. And even we have sutureless valves in form of technology, which provides the valves which are actually implanted surgical form of the TAVR, you can say, and in which we can cut down on the CPB time by less than 10 minutes or 5 minutes. And you can see this stuck aortic prosthesis in which we have to go in the emergency surgery, and you can see the clots which are stuck at the valve. And explanted valve is there. And you can see while we are doing the valve replacement, we have to do some other procedure along with, like LA reduction, so that you can see the X-ray with the CT ratio of almost 1 to the CT ratio of almost 0.6 by reducing. And this is the MICS. In this case, this particular patient, he was a case of infective endocarditis of aortic valve in which vegetation was approximately 2.6 centimeter to 1 centimeter. And after stabilizing him and controlling the septic condition, he has to, and he has he already has a multiple thromboembolic phenomena. So we did his partial hemisternotomy, and patient is doing well. And you can see this non-coronary cusp get eroded by the vegetation, and you can see the hole in between. In the aortic surgery, aortic root aneurysm, aortic dissections, and post-traumatic aortic transactions we are seeing quite, and we did 2, and we were able to save their lives post-procedure. In the aortic surgeries, we are doing hybrid surgeries like and endovascular repairs as well. You can see this dissection, and this is another case in which we did aortic root replacement, and this is the post-traumatic aortic transaction in which we did endovascular therapy, so that you can see the whole area is covered with the stented graft. And the same patient, and you can see this leaking arch aneurysm in which a whole hemithorax is filled with the blood. And what we did is a debranching of the brain neck vessels, and after that we covered whole area with the endovascular stent. You can see the images. And this is the surgically we have done debranching, and after that we have covered. You can see in the pediatric cases we are doing atrial septal defect, ventricular and subaortic, and RSOV repair, and everything we are doing, and we will take care. This is a particular case of ASD with the severe mitral regurgitation in a 6-year-old male child with the severe TR, in which we repaired the valve because replacing the valve at this stage is not a very good idea. So we have to repair this valve, and we did successfully. Last but not least, emergency cardiac surgery is most important because that creates a faith of the society in a center or a doctor by providing the emergency services. When you are in pain, somebody came to a severe, that is the ultimate thing. And we are providing services in the acute aortic dissections, post-traumatic aortic dissections, critical left main disease, and patients who are having ongoing chest pain. At the mid of night, Dr. Pramod used to call me, he's this guy, and this is not doing, and this is, the vessels targets are not plastable, so can we go for surgery at this time? Definitely after arranging the blood, we go for, and these are the surgery, end stage heart. Already we are doing ECMOs, and we are already having 2 patients on ECMO going on, and definitely I would like to extend this program to LVAD, RV assist devices and biventricular devices along with the heart transplant. So next in line will apply for the heart transplant as well. But thank you very much.
Thank you, Dr. Sanjay. Now I'll ask my colleague.
Thank you, Sanjay.
My colleague Dr. Sanjeev from Head of Department from AIMS Patna to give his view.
Thank you, Sanjay, for a very elaborate description of what are you doing. We are thankful that you are carrying on the cardiac surgical program in Patna in a very big way. And you have done almost all cases, emergency. One thing is I would like to discuss about the ECMO. Because in routine cases, it's all right, but in emergencies or in severe cardiac failure, you have to do surgery. We have used ECMO in 2 patients in the last 6 months. And in the post-operative period, in day 1 in ICU. But unfortunately, both patients could not survive after 4 days. So is there any tips when to apply ECMO on the operation table or watch for some times for IVP, and what should be the...
Till now we have not applied in post-cardiotomy syndrome, what we call, but definitely before that for stabilization, like Dr. Shamshad already has shown that severe LV dysfunction. Maybe that kid was suffering from a viral myocarditis, so that after a week he recovered dramatically. And I think time is very important in deciding the outcome of the therapy. At what time you are going to apply. I think that is the key. We applied at the right time, and definitely, and that patient did well. And still last night also we put one patient on ECMO because he was suffering from an acute MI. His left main, distal left main was blocked, RC was blocked, only he was surviving on one ramus was there. So it was very difficult for along with the severe MR. So initially we did IABP, but in spite of that, that patient developed shock, and shock was continuing, requiring high inotropes. So we put that patient on ECMO last night, and right now his inotropic requirement has lessened, and we are planning in a day or two for go for a definitive surgery.
Just putting ECMO before surgery?
Before surgery.
That.
I think before a patient goes into vicious cycle of multi-organ failure, before that if we put the ECMO, then it will be beneficial for the patient.
Definitely. So time is very important for
post-cardiotomy syndrome patients actually fare worse. I'm sorry, I'm Dr. Praveer here. Sir, as per the international data also, post-cardiotomy syndrome patients put on ECMO fare much worse as compared to patients who are put pre-operatively, because of the surgical stress, and anyways we are putting them post-cardiotomy as a salvage, we are putting them on a ECMO. So these patients anyways would fare much worse as compared to regular patients.
But patients with coronary artery disease, as Dr. Sanjay has rightly mentioned, left main, critical left main with all those. So what is the likely chances of improvement with ECMO per se without going for a surgery?
So
how long can we wait for it?
Not we are going him to wean him off ECMO without surgery. Definitely we are going to proceed with the surgery, and in that case that ECMO support will continue till the recovery from the
So what is the time frame? That is how long can we wait for? Because that ECMO again is an extracorporeal circuit.
No, we should not wait. At least we should provide some time other organs to recover from a persistent low cardiac output, and that will help you. In fact, even during we could have proceeded for the surgery, but attendants take time to decide for the ECMO. That is because in this case we could have gone for surgery, but because in that ECMO case we required ECMO after surgery, post cardiotomy. But attendants are not, they also take their own time to decide, and that time passes, then also I think...
The problem with ECMO is it adds to the burden of financial burden.
Definitely,
that is one thing which we have to take into consideration, because the financial burden, if the patient is well off...
you know, finances, but life is ultimate.
That's very true. That's very true.
One more question, Dr. Sanjay.
I want to add one more.
Is recent advantage in cardiac surgery Bihar perfect?
Yes, sir.
Underlying Bihar perfect. Now you said it might valve repair surgery. Now in my experience, and maybe others also, that the valve pathology which we get in Bihar is rheumatic, post-rheumatic.
Yes.
And they are all, well, you can say frozen valve, and I personally think they are not amenable to repair. Now, in your experience, what is the result of repair for mitral valve?
For rheumatic heart diseases, sir, I don't think repair is a good option for our subset of the patient, because these valves are not going to last long after repair. Even we have seen they are coming back after 3 years or 2 years. So that is not long lasting, because we are not going to treat the original disease of the patient. Original disease of rheumatic heart disease is going to continue. That will represent as a sequelae. And I think in those cases, until unless it is warranted by the females of a young age, that is the only thing that warrant us to repair in rheumatic heart diseases. Otherwise, myxomatous valves, valve prolapse, these are the cases in which repair is definitely can be done.
Yes, rightly. For rheumatic heart disease, repair is not an option.
Not only
we should
CMV is the option. Or
only we are forced to do.
Yes. Sir.
Sometimes there are reasons like cardiologist pressures or family pressure or colleagues. So this is a very nice presentation, Sanjay. Thank you very much. There is no question. I think we should congratulate him for his works. Rather than question. Thank you, Sanjay.
One thing I will like to add for ECMO. Putting an ECMO is similar to decision that when you have to open the parachute while you are falling. The earlier you open the parachute, the time you will take more to land down. And the late you will open the parachute, you will crash down. So basically, whenever we are dealing in a patient with cardiogenic shock and heart failure, so the transition from a warm and wet to a wet and cold, that boundary has to be decided first, because we are not going to let our patient to land in wet and cold, because putting ECMO when the patient is wet and cold phase of heart failure, then it is not going to help. And if we are putting ECMO in the initial phase of warm and wet, then also it will not, because it will add on more complication, because the duration of the duration up till which an ECMO has to be in the patient, it will add on to the complications. So ECMO for shortest period and ECMO at right time, it is very important.
Thank you. Thank you very much for example and explanation. So we just must call it a day. Thank you.
Thank you, chairpersons and speaker, for a wonderful talk. We'll go on to our next session. And I would like to invite our chairpersons for the same, for the next session on organ donation and heart transplantation. So first, Dr. Prakash Dubey, sir, Professor of Anesthesia Department, IGIMS. Dr. Manish Mandal, sir, Medical Superintendent and SOTO Chief from IGIMS. He's a Senior Gastroenterologist. Professor Dr. Ashutosh Jha, Head of Department Anesthesia, Katihar Medical College. Dr. Prasoon Ghosh, Senior Director Urology and Renal Transplant Surgeon. So please, you are welcome on the dais. I'll request our chairpersons to introduce our next speaker, Dr. Rajiv Ranjan, the man behind all the successful cardiac surgeries here.
Good afternoon. Dr. Rajiv Ranjan, he is the Director in Cardiovascular Anesthesia in Jayaprabha Medanta Super Specialty Hospital at Patna. He has completed his MBBS from Ryan Medical College, Ranchi, and MD from Patna Medical College. After that, he did his PDCC from SGPGIMS, Lucknow. Dr. Rajiv Ranjan specializes in ICU care of critically ill patients, administering cardiac anesthesia, cardiac transplant, perioperative care, and transesophageal echocardiography. He was working with Medanta Gurugram prior to joining to Jayaprabha Patna. He was authored multiple articles in Indian and international journals of repute. With this, I request Dr. Rajiv to go ahead with his deliberation.
Thank you, sir, for the kind introduction. Today, this afternoon, we are going to discuss about organ transplantation, heart transplant. There are two good reasons to talk about this organ transplantation. First, that our SOTO Chief, State SOTO Chief, Dr. Manish Mandal is along with us. And one more important thing is that yesterday only I came to know that there is an organization which takes care of transplanted patients, organ transplanted patients, Special Olympics. That is basically affiliated to World International Olympic Association, and that World Transplanted People Olympic is going to start today at Perth in Australia. So on this note, as we have learned right from our childhood, Raktadan Mahadan and Angdan Mahadan. So why it is important? Why it is important to pledge ourselves? Before I forget, that there is a NOTO, which is basically a national organ and tissue transplant organization. In that, form number 7 is for all of us, where we can pledge our organs for donation after we leave this world. Look at this yearly estimate in India. Where do we stand? We need at around Astosh. ये कहाँ काम करता है? वो नहीं यार। कहाँ गया आशुतोष? So what we need actually is too much. We need around 2 lakhs kidney per year, but what is available to us is around 10,000, out of which 8,000 is from live donors and 2,000 from brain dead people. So the deficit is around 95%. Same story with liver, and in the heart we need yearly around 50,000 hearts, but only 350 is available in this country. Look at how much we are getting after organ donations. Only 2,000 for kidneys and 500 for liver. What I mean to say is, if the organ donation is going to increase in this country, the number will go up, the deficit will definitely come down. This is the data during COVID period in 2020 from Roto, Western Roto. In Mumbai, they had around 5,000 kidney transplant registry, but only around 99 got the kidneys. And regarding 1,000 for liver, only 69 got the liver from organ donation. Look at the status of organ donations in different countries, which is led by Spain, which is a very high number, 46.5 donations per million of population. Very closely followed by Croatia, 38.6. And where do we stand? We stand at around 0.4 donations per million of population. So there is a lot of scope for us to improve and increase the organ donation pledge. Keeping in mind about that organ donation, the government of India in 1994 brought the TOTA Act, that the Organ and Tissue Transplantation Act, that was further amended in 2011. So there they define the close relatives who can donate it, because the government does not want any financial trade should be involved in this. And one thing I would like to add into that during the amendment in 2001, government has also added not only the close relative, blood relatives, wife, husband, spouse means. Apart from that, if somebody proves that he or she is closely related to the patient, maybe right from the childhood, maybe a childhood friend, maybe a person who is involved with the patient for a pretty long period, he or she can prove to the authorities that they are capable of proving the relationship with the patient, they can also go for donations. So what are the organs that can be donated? heart, liver, kidney, lungs, pancreas and intestine. And there are certain tissues which are also there in the list. So, when to do donations? We know about brain dead and coma patients. We all know the coma could be a reversible process, but brain dead people means there is a patient whose brain stem is not working. Why brain stem death is important? Why do you want to say not the forebrain, brain stem? Why? Because most of the vital centers are located into the brain stem, and if the patient is not, the brain stem is not functioning, the patient is dead, cannot be revived if the patient is disconnected from the ventilator. So, as I mentioned, we have NOTO, that is a National Organization for Organ and Tissue Transplant Organization with headquarters at Safdarjung Hospital. Then we have SOTO, that is State Organ and Tissue Transplant Organization. And for a better coordination between the states, the country has been divided into many regions, and so there is a roto in between. This is the Eastern Roto. We can see where here we stand at Bihar, and Dr. Manish Mandal from IGIMS Patna, who is also the chairperson of the session, is the SOTO chief of the state. Now, talking something about heart failure treatment, when the medical therapy ends and the patient is still in failure, what are the options available to us? There are three modalities which are available to us. One is extracorporeal membrane oxygenation. I think Kishore will talk about it in detail. A lot of talk has been given regarding ECMO. Then we have ventricular assist device. It could be a left ventricular assist device, it could be right ventricular assist device, could be BiVAD, and the last but most important is heart transplantation. This is the ECMO patient which we did, and we decannulated the patient later on, and the patient went home successfully. And we were able to extubate the patient on ECMO. He was eating, he was talking, he was behaving all right, but we had to support the patient's heart for around 7 to 8 days. He was absolutely fine, and after 7 to 8 days it was decannulated and the patient went home well. Thanks to our cardiology team led by Dr. Pramod sir, who had referred these kind of patients for the ECMO program to run, and we are doing it successfully. I will now talk something about the donations after. There is a new concept which has come, that is the donation after brain. This is an old concept, donation after brain death. There is a new concept also, donation after cardiac death. There are certain hospitals in Australia, UK and US which are accepting heart after natural death of the patients. Within 30 minutes they have even used the heart harvested after natural death within 2 hours. So you can imagine the heart has fibrillated, the heart has gone down, the ATPs have been depleted. Even after that, the heart has been put on certain machines. The nutrition has been given, the blood has been given, the oxygen has been given, and the heart has revived. It's such a beautiful organ, and they have put it for a few hours and found it to be working well, and they have placed it, and the results were excellent. So heart transplantation is nothing but when an end stage failure, the heart is removed and a new heart has been placed from a donor heart. There are certain patient selection criteria which I am not going in detail because of paucity of the time, But patients with end-stage cardiac disease with LV function less than 20% and a life expectancy of less than 6 months will be considered for transplantation. There are certain exclusion criteria which must keep in mind that if you put a patient for transplantation, you do a cardiac transplantation, and there are certain regions which are not sustainable for life for the patient, then it will be a worthless thing. So, as I mentioned beforehand, we have to, for the procurement of the donor heart, when the heart is available, we must ascertain the cause of the death, what is the recent course of the patient, how much anotropy he has gone through, how is the heart function. So basically we have to see how healthy is the heart or kitna pita hua hai. Between these two we have to choose between. There are certain criteria for acceptable donors. What happens, we have a registry of patients in NOTO where the patients who are looking for heart transplantations, names have been listed because their LV function is less, their life expectancy is poor. So these patients are referred to the related hospitals and they are properly worked up right from head to toe that these patients are proper candidate for the heart transplantation. I'll not go in detail because of paucity of the time. Now, once we have got the heart, our team has procured the heart at a distant center and the heart has to come to our hospital. As we all know, as far as heart is concerned, the ischemia time is maximally 4 hours. After taking from the donor, we have to put the heart into the recipient within 4 hours of harvesting. So synchronization with the procurement team is pretty much essential. Immunosuppression should be started before wheeling in the recipient, and the proper amount of blood should be available in the operating theater. Transesophageal echo probe is a must. This is the way the heart comes to your operating room. This is a 3-layer plastic bag packing and put in ice packs. So this is the routine practice all over the world to bring the heart. Here you can see there is a PA catheter, there is a transesophageal probe, and the center line, the pulmonary artery catheter, all is from the left side. Why? Because we want to keep the right side free. If in the further course, if you want to do some kind of cardiac biopsy, this is a straight path rather than the left path. So from the IJV to SVC, from RA crossing the tricuspid, we can reach the right ventricle and we take up biopsy from there in the due course. This is a perfect recipient after induction of anesthesia. So here is the case, pressures are almost fine. There is a very, very low PA pressures in yellow. So we are very much concerned about the high PA pressures when the recipient heart comes to the patient. It could be like that the PA pressures are high and the RV starts failing straight away. So for the heart transplantation, for the surgeons, there are 3 main steps. One is transection of the great vessels. Number 2, you disconnect the SVC and RA and IVC and RA, so the RA dissection. And number 3, you remove the LA from its floor. You can see the great vessel disconnection is taking place. I'm sorry, the video is not very close up one. This is the left atrial dissection going on. So the whole process of removing the heart starts only once the heart reaches the operating room. Once the heart comes to the operating room, what happens is it takes hardly 15 to 20 minutes to remove the diseased heart from the patient. So this is the final stage of left atrial dissection, where the heart is separated from the body wall, and very soon the heart will get free from the body. In the meantime, when this dissection is going on, somebody from the team is preparing the recipient heart. That is also very important. So ultimately the deceased heart comes out of the human body. And by this stage, what happens on cardiopulmonary bypass, the heart which has come, the donor heart is almost ready for transplantation. So after removing the heart, this is a very rare kind of situation of the pericardium, where you can see the SVC, IVC, great vessels all clamped from the upper end, but the pericardium has no heart. It's absolutely empty pericardium. Now, as I mentioned beforehand, during this part, other team members are preparing the heart. What happens is that nowadays, when you go for heart procurement, there are 4 teams working simultaneously. There is a liver team, there is a heart team, there is a kidney team. So what happens between liver team and the heart team? We both are concerned about the IVC, inferior vena cava. They also want good chunk of IVC. The cardiac people also want good chunk of IVC. And during this dissection of this IVC, what happens? There's a rugged edges where the great vessels or SVC or IVC. So you prepare by putting certain kind of collar. And ultimately, what happens is, when the heart has been transplanted, one can appreciate the suture line of the pulmonary artery and the aorta. Now, little bit about immunosuppressions. All these are possible, all the transplants are possible because of the immunosuppression. The best part of cardiac transplant is we only look for blood group. We don't go for any other immuno investigations like HLA or something like that. Blood group works well for us. About immunosuppressants, there are 3 drugs. One is calcineurin derivative inhibitors, number 2 is mycophenolate, and third is steroid, which is mostly the methylprednisolone, which we start. Methylprednisolone is given before pushing the patient into the operating room, and number 2, second time it is given when we open the cross clamp. First time the blood comes in contact with the received heart. So that is a point of time when the chances of high immune reactions are there. You give it proper antibiotics. These patients are immunocompromised, so they basically are mostly put on isolation. When there is a when you are feeling like the heart is working well, you don't bother about anything. You do a echocardiography morning and evening and see how the heart is behaving after transplant. If you find the heart is not working well, the ejection fraction is coming down, the RV is not sustaining, the tricuspid regurgitation is going up, this is the time to go for a biopsy. So as I mentioned beforehand, from IJV to SVC to RA to RV, we take a chunk of it and send it for immuno cells to be seen by the pathology people. And if everything goes good and well, after the cardiac transplant, the patient gets discharged about 18 to 25 days, 3 to 4 weeks time. Thank you.
Thank you, Dr. Rajiv. Well-deliberated lecture. As a SOTO chairman of Bihar, I have been trying my level best to increase the awareness in Bihar, because twice we have done explant at IJMS Patna and sent it to Delhi or to Kolkata as was told by our roto. So I'm trying my best as a chairperson of Soto Bihar.
Sir, as we have already applied to you for kidney transplantation recently, and we are looking forward for heart transplantation application in coming days. So what I can do, I can assure you from the Medanta side that in coming days you will not have to send the organs to some other state. The organ will remain in the same state and the organs will be put in our patients only.
No, for kidney transplant it's not an issue because there are many stakeholders at Patna at present. But the only issue at present is that our heart are sent to other centers. So I would love to have a center at either our center IJMS or AIMS or any good center like Medanta who can come up with this heart transplant program. As far as I know, at IJMS we have already had 98 kidney transplants, more than 600 corneal transplants, 1 liver explant and 1 liver transplant was done at IJMS. And at many other centers at Ruban also 1 kidney transplant has been done. At Paras also it's done. So in my knowledge and as a Soto chairman, I am focusing more on the heart transplant because that is the only area where Bihar is lagging and there is no other person. So it would delight me if any stakeholder is there in Bihar. And as far as your question was concerned about the kidney transplant, normally when you apply for the transplant, the file goes to the Department of Health and from there they send papers to us. Then we as a Soto examine in-house to your center because there are parameters. That parameters has to be checked. After filling that parameters, we certify it and send it to Roto as well as Noto. And then they give the paper back and then we submit in the government and then you get this certificate that you can start your kidney transplant. That is not an issue. We would love to have more and more stakeholders for kidney, for liver, for pancreas, for intestines, because that is going to benefit everybody in Bihar. Because Bihar money and energy is draining outside in all these transplant programs.
Absolutely. That's what I was trying to mention, that in coming days, along with kidney, the heart will also not go outside Bihar.
Thank you, Rajiv, for sharing your thoughts. And we all know that both Rajiv and Dr. Sanjay have been trained in heart transplant in US and they have been working in the cardiac transplant team for a long time. We have done 2 organ retrieval surgeries at IJMS and what I feel that awareness and motivation is the main problem with us. And in both cases, we had identified the potential organ donor in our ICU, but the consent came very late. Aaj haan, kal na. These were the things, and by that time, because we know that the management of potential donor in the ICU is the most challenging thing in the critical care area. And both the times we were feeling frustrated in between that why we are not getting their consent, in spite of they are saying that we are ready to donate, but the actual consent came quite late. So I think that
this is
awareness and motivation.
There comes the role of the transplant coordinator and the social worker who keeps in touch with the patients who are potential brain dead patient, and they keep updating them about this.
That is the area which I feel that needs lots of work.
So actually it was a very good deliberation, लेकिन एक मुझे लगता है कि बिहेवियरल चेंज की बहुत ज़्यादा ज़रूरत है. मैं जब एज एनेस्थीसिया टीचर पढ़ाने लगता हूँ, जब लास्ट के 2-4 लेक्चर बचते हैं, मैं पूछता हूँ छात्रों को कि आपको कभी पढ़ाई हुआ या किसी भी सब्जेक्ट में, और आंसर ना में मिलता. हम लोग अक्सर बात करते हैं कि जनरल मास को एजुकेट करें, पहले जो हमारे प्रोडक्ट्स निकल रहे हैं उनमें अवेयरनेस हो. जैसे भाग्य से सोटो के चेयरमैन ही यहाँ बैठे बिहार के, तो कम से कम ये जरूर करें कि ये जो बच्चे MBBS करते हैं उनको इसकी प्रॉपर ट्रेनिंग हो. अभी भी जैसे इतना अच्छा लेक्चर हो रहा था, हम लोगों ने सुना, लेकिन आधा क्या मैं समझता हूँ 75% लोगों ने सोचा होगा कि नहीं लेक्चर तो बहुत अच्छा लेकिन ये हो नहीं पाएगा. जो सबसे पहले इसको बदलने की जरूरत है. मैं आपको बता दूं कि राजस्थान का जयपुर का एक 2010 का मेडिकल कॉलेज है, उसने पिछले साल 300 किडनी ट्रांसप्लांट कर दिया और 126 उसमें से अनमैच्ड उसने कर दिया 300 एक साल में। तो ये बिहेवियर को behavioral changes की जरूरत।
In initial stages, definitely there are hitches. Dr. Trehan had selected 6 people in 2011 for training in cardiac transplant, and me and Dr. Sanjay were lucky one to be among them, and we were sent to US, and we started the. We had gone to 2012. It took us 2 years for doing the first cardiac transplant in 2014. So initial hitches are there, but I am very sure that the kind of organ available in our roto, and number 2, the facilities available in Medanta, Jayaprabha Medanta Patna, very shortly we can start cardiac transplant as well.
वेरी नाइस। लेकिन वही जो लोअर लेवल है, जो बच्चे एमबीबीएस करते हैं, नर्सिंग करते हैं, उस लेवल पर इसको बहुत सीरियसली उनको अवेयर करने की जरूरत है। वहां से आपको आके ट्रांसप्लांट के लिए जो आएंगे, डोनर्स आएंगे, वो लोअर लेवल से आएंगे,
के लिए सेंसिटाइज करने की जरूरत है।
वर्क एट दैट लेवल आल्सो। मैं हमेशा हर बैच में मैं एक्सपीरियंस लेता हूं, पता चलता है मेडिसिन, सर्जरी सब कुछ पढ़ के आ गया, लेकिन इस टॉपिक पर कहीं कोई क्लास हुई नहीं। मैं लेता हूं, बहुत अच्छा आपका लेक्चर लगा, मैं लेता हूं, और मैं कहता हूं कि नहीं, ये भी आगे के समय में एक काफी ब्रॉड फील्ड होगा, काफी स्कोप, इसमें बहुत काम किए जाने की जरूरत है।
We have transplant surgeon Dr. Ghosh as well.
Yeah, excellent presentation, Rajiv.
Thank you.
I'll just confirm what other people are saying. The biggest hurdle to the organ transplantation from deceased donors is basically ignorance and lack of awareness. Our Prime Minister was kind enough to speak it at Man Ki Baat program. There are excellent programs run by Noto, Soto, Roto, other things across the country for just this keeping those awareness programs going on. Now, these awareness programs can't be delivered overnight. It has to start right from the grassroots level. Imagine somebody being asked or counseled to donate for a deceased donor donation, and the family asking the question, अगले जन्म में क्या ये बिना किडनी या बिना लिवर के पैदा होंगे? Now, there is absolutely no sense to this question, but this just depicts and reflects the kind of ignorance that exists in the mass population.
Correct.
Starting from religious beliefs to societal beliefs to community beliefs, everything, it has to be tackled from down up rather than up down.
Absolutely.
So, faces who are kind of recognizable, brands and everybody, there's a huge push towards organ donation. Down south, almost 80%, let me put it the other way around, it's about a 50-50 live donor versus a deceased donor program. But the moment you climb up towards north or east maybe, suddenly it all fizzles out. Of all the transplants that I have been doing since 2001, 80% of my donors are live donor programs. And of them, 80% are females. Now, this is surprising in a country like ours, as big as ours, but as you mentioned in your slide, our deceased donor is like less than 0.4%. So, government is coming out, like next time you are applying for a driver's license, there will be a heart printed out onto your license. You are in an organ donation scenario unless you voluntarily wish to opt out. So it's more of an opt-in program. I think, Chairman Sir, you can agree to that.
If you go to our Noto website, there is a form number 7.
I'll just wind up as a Soto chairman. We have taken note of these things since we have started late at Bihar. Soto was established somewhere around just 2018.
That's correct.
So I have tried my level best to reach out to the periphery also, as you told. In this year, every month we are doing program, one for school, one for college, and one for office. 3 programs in 1 month. This month we are going to Siwan to have the awareness program there. There is a NGO working Parivartan at Siwan. So there we are going for the transplant, for the awareness part. We have covered almost 18 schools at Patna, be it DPS, be it St. Michael's, be it Notre Dame, St. Xavier's, Radiant School, 2 of the parts of the branches of DAV school. So at school level, at college level, we have gone to Patna Women's College, which is the leading women's college here. And as rightly told by you, we'll give guidelines to all the medical colleges, be it private or government, that they should have lectures compulsorily on organ transplant and organ donation. They should know where it is going on in Bihar and about the Form 7, what is the online donation is there, pledge forms. And we have also covered many of the programs of the government. Like recently we had Bihar Divas. In that there was program at Gandhi Maidan. And for 3 days, our total stall was there. We got about 198 pledges that in last 3 days of this Bihar Divas. So people are coming at, but yes, sky is the limit to make awareness in Bihar about the transplanted program.
I'm sure that the doctors here from Bihar, from all nooks and corners, they will also spread this news of organ donation and start sensitizing people. Thank you.
Thank you.
I'll request our chairpersons to be here, sir, for the felicitation ceremony. I'll request Dr. Rajiv Ranjan Prasad, sir, Director Radiation Oncology, to come and felicitate our chairpersons. Dr. Prakash Dubey, sir. Next, Dr. Ashutosh Jha, sir, please. Dr. Prasoon Ghosh, sir. Everybody is hungry, but please clap. I'd request Dr. Ajay sir to come and felicitate our chairperson of the previous session, sir. We'll be calling Dr. Vikas Singh, sir.
विकास आ जाइए.
Now request Dr. A.K. Gupta, sir. Please come on the stage. Now I request Dr. Arvind Kumar, sir. Dr. Arvind Kumar, sir. I think he is. Now I would request Dr. Ravi Vishnu, sir. Please come on the stage. Now I would request Dr. Sanjeev Kumar, sir. Now I would request Dr. Sheel Avnish, sir, to please come on stage. Dr. Sheel Avnish. I think he has left. Request Dr. Vipin. Dr. Vipin, sir, from Urban Hospital. So we'll be sending these mementos to them. Dr. Vijay Sheel Gautam, sir.
Vijay Sheel, आ जाओ. अरे भाई, याद करोगे कि मैंने तुम्हें forward किया.
Thank you, sir. Thank you, Ajay, sir. Now I would request. I request Dr. Sanjay, sir, to please felicitate all the speakers, the other speakers. Sir, आप आइए ना. Dr. Shaheen Ahmed, sir. आप बाकी लोगों को Dr. Shamshad Alam. Dr. Pavan Kumar. Please come. Dr. Rajiv Ranjan, sir. Now I would like to request Ajay sir. Ajay sir, please come and felicitate Dr. Sanjay. That's a nice picture moment. ये भी ले लीजिए सर, इसको देके. So that concludes our pre-lunch session. So we are done with the cardiac session. Sir, आपका मिलेगा. हाँ सर, बात